see any hyperostosis. There's nothing suspicious at all there. And that is making me a little back-footed on doing I should not do an overkill. I mean, yes, I should treat the patient, but I cannot subject him to a draft 3 just because I have to do it, because I plan to do it. No, I have to take the call intraoperatively sometimes, of course. So let us see. I'm very sure that there is no attachment there. There's no residual tumor. Give me a frontal sinus suction tip. Now it's turning out to be an anticlimax for me. Anticlimax.
But post-operative surveillance of the cavity and the tumor recurrence, will that be a factor in deciding?
Absolutely. So I'll be asking him to come for follow-up regularly, and I'll be visualizing the frontal recess every 15 days. And that will be actually a very important part of my follow-up protocol. So that will decide. Let's see. I'm going to be very meticulous. I'm going to see what's happening. Give me a upturn, Blex, please. As you said, the post-operative follow-up is very, very important in such cases.
And how long do you tend to follow these patients?
I tend to follow minimum 3 years. Minimum 3 years. I've seen one case where the patient was normal and he came back with a recurrence after 2 years. I don't know. I mean, very sinister, but then.
Do you do any imaging for part of your follow-up sometime?
See, basically, nasal endoscopy is such a beautiful thing. If inaccessible areas are, like, for example, infratemporal fossa, such areas are involved, then imaging makes sense. If, the frontal and the ethmoids are going to be involved, there's no sense in imaging because you're seeing it directly. Every time you're going to follow up that patient, you're going to see that area. So I think imaging is reserved for areas.
See, when you've done a meticulous resection and you're happy that you found the point of origin, what is the recurrence rate in your hands?
In my hands, recurrence rate. Basically, honestly, I'm telling you, I'm a very radical surgeon.
Yes.
Even though I'm radical, I have a recurrence rate of around 8% or so, 8 to 10%. I may not be able to be exact in that, but I have had recurrences because of the aggressive nature of the disease. So sometimes it goes to infratemporal fossa, it goes into, parapharyngeal space. I've seen extensive cases, and that extensive, sometimes it goes beyond the dura. We have operated on inverted papillomas, many which actually breach the dura. I resect the dura, go into the brain, but even then, you can not be very sure that, see, that's the anterethmoidal artery. Very beautifully seen anterethmoidal artery. Now, my only thing is that, is there tumor left behind or not?
Will be transecting the anterethmoid, or are you trying to?
Come again, please.
Are you going to transect the anterethmoid, or are you just trying to see beyond it?
I don't think so. I don't think it's needed, right?
Okay.
Do you think so? I don't think so.
Okay.
That's all the olfactory. See the olfactory filaments here. They all, see that, very beautifully seen. See that?
Yes.
Very nicely seen. Give me an upturn. I think I'm very happy with the. See, if you drill, let us assume that I'm going to drill. Anything less than draft 3 is going to stenose. So that's going to actually, I can't examine the frontal after that. That's actually going to be a bigger problem. So I'm trying to avoid drilling. If I drill, then you expose raw bone nicely, you have heat, that leads to neoosteogenesis, and I can't examine this frontal again. So basically, the question of draft 2A is out of my mind in most of my cases. Either it's going to be a wider opening or it's going to be a draft 3. So this is my dictum. You can see here that this is almost clear. The skull base is also very beautifully clear. Give me a upturn Blexley. I'm going to take this out. No, there's nothing like that. Yeah, there was a little bleeding here. That could be one of the sites. Maybe it was attached to the lamina. I'm not very sure. I wanted to demonstrate a draft 3 desperately, but I'm sorry. The situation didn't demand it. Yeah, I think you can intubate the JNA.
It's intubated. Shall I go get it ready?
Wait.
Yeah, that's all. It's again a good learning. That another example about dynamic surgical decision making.
Yes.
That you develop some strategies and you adapt as you go along, depending on
See
the
the
findings.
anteriothmoid
and
artery?
situations.
Can you see the anteriothmoid artery here?
Yes.
Very beautifully seen. No, that is not disease mucosa. There is nothing like that. Okay, give me a coblation. Let me coblate it. So in meningioma surgery, we always say Simpson's grading, right? So we all know about it. Simpsons 1, Simpsons 2, Simpsons 0. So I perform a lot of intracranial straight suction, man. Intracranial meningioma surgeries. And for that, sometimes when we are not able to, completely resect, we at least cauterize it and come out. So we have a Simpsons 3 or something like that. So like that, I'll have a decent compromise of actually cobblating all this area. And then coming out. That's exactly what I'm going to do. So this area was bleeding a little. Apart from that, I don't see any area which is involved by the tumor. Let me check the middle turbinate. Okay, here. Okay, give me a debrider. So basically inspecting areas, suspicious areas, very important. I'm just going to inspect this area. There's nothing over there. That's the superior turbinate. There's nothing over there. So here, I'm quite happy. You have any opinions, Dr. Louis?
I do. And I think actually knowing when to stop is one of the most difficult decisions in surgery. And I think looking at that, the mucosa macroscopically is looking clear. There's no obvious inverted papilloma at all with a point of attachment going into the frontal. And I think you need to think about if you were to do the draft 3 and you were to have a complication of that, looking back and thinking, did I need to do that? And so exactly. I would agree. I think if intraoperatively, if you discover that actually things are not as extensive as you had planned, then you do what is required, not what you've originally planned. I think it's important to change your plan intraoperatively and do what's best for the patient.
Absolutely. I fully agree with you. Very, very nice comment. And I think Dr. Ashok, any comments? I'm going to close the case now.
Yeah, I think it's very nicely demonstrated that how to approach this type of tumors with the thorough review of the imaging, making sure you got the CT, you got the MRI, you have assessed beforehand that what sinuses are likely to be involved. So you got some structure in your mind, made some strategies, some plan. And you also have shown how one needs to be flexible and adapt to the findings during the surgery. So you need to have all the techniques under your armamentarium and use those techniques. And of course, clearance of the papilloma, dealing with the mucosa. We've seen from yourself and also from Prof. Paulo how different approaches are required depending on the pathology. So the last pathology was a nasal polyps. So you have been very diligent about mucosal preservation. And equally, in this case, you're very particular about all the mucosa is removed and the disease is cleared. Not only after the clearance of the mucosa, you're also using this coagulation to build as a belt and braces approach. Make sure that all the mucosa and any remnants, any tags are dealt with adequately. So thank you. That was a wonderful demonstration.
I think the carry home message to the youngsters is that I think a surgeon should know when to stop, even though you are having a decision pre-operatively. I think intra-op decisions make a lot of difference depending upon, as you said, the follow-up and things like that. So I think a good surgeon should change or permute his combinations according to what he sees intraoperatively, and not to do too much just because you have planned it before. This is something which is an important carry-home message in this particular case.
And yeah, I
I
think
absolutely agree.
it will be interesting to see how this patient does over his period of, say, the next 3 to 5 years.
So thank you very much, and that's the end
Thank you.
result of your surgery.
It's
I'll
fantastic.
Thank
be
you. So,
angiofibromas.
do you have any final comments, Dr. Jankira, about the case?
My comments about inverted papilloma is that again and again I say that we should be very radical in inverted papilloma. Recurrence rate is high. Close monitoring post-op. In case inaccessible areas are there, you have to follow up with MRIs. And I think MRI is a must for inverted papilloma. Don't operate with a CT scan because you are going to do an overkill. I would have done a Denkers. If I had done a CT alone, I would have done a Denkers surgery. Well, I mean, in the pre-lacrimal approach, which was not required at all. So these are all the carry-home messages for youngsters who are starting with IPs.
Great. Thank you.
Thank you very much, Dr. Ashok. I'll be starting the
Thank
next
you.
case. They have intubated the case now. Another
Okay.
10 minutes, I'll be starting the next case.
Perfect. So thank you. So look forward to joining you there. And it's another interesting case of JNA.
Yeah, that's a JNA. And that's actually it's a very difficult JNA because already operated and maxillary swing done, parietal perforation is there. And that is going to be a very, very challenging case.
It's getting
It'll be
more
nice.
exciting.
Yes.
I'm so thankful to your team for honoring us with this beautiful program.
Thank you. And likewise, thank you
Yes.
to your team, all your fellows. They're doing a wonderful job. Monica and your other fellow who presented today. And
Yeah.
your theater team, your anesthetists, they're trying their best to
Dr. Bala is my
Excellent.
anesthetist. In fact, we have been working for the past 20 years or so, and he understands when I want the hypertensive and when I want the pulse to go down, and that way, we work in synchrony. Thank you, Dr. Bala, for the wonderful job. Thank you. We also have
you.
some fellows from Mozambique. This guy is Archimedes from Mozambique, who is here.
Hi.
Hello, Archimedes. Hi. It's great to see you.
Hello.
Okay. Thank you very much.
Great. So it's a
Thank
really
you.
good global,
See
you've
you
got
in
a
10
global
minutes.
audience there indeed.
Thank you.
Thank you.
I think,
think,
Ashok, sorry, I was just going to say phenomenal when you think about the timing and the number of cases that we've just seen being done so effectively and meticulously. We've
Yeah.
only been here for sort of 5 hours and the number of cases has been quite incredible.
Yeah, exactly. And that's the whole ethos of the teamwork. And
Yeah, absolutely.
high volume centers. So they're geared up for that. And
Yeah. Yeah.
they probably streamline the whole process of getting the patient ready and
That's
the
right.
changeovers.
Yes.
I think that's the key in these situations. So it's quite a cultural thing from the work it's in culture and how you set your work pattern. So that's indeed
Absolutely.
very huge numbers. And
Yeah.
but that's great for our audience that on a
Fantastic.
single day we get to see all these variation and variety
That's
of
right.
cases. So fantastic. So I think even the Prof. Castanova, we talked about this case, and it was a wonderful case. There was a question about how long this patient will be staying. So I think we'll get back to Prof. When and ask that question. But I guess he said that they're going to keep the pack at least for 24 hours. The marrow cells will be coming out after 24
Yes.
hours. And then they also had put a frontal stent to support the flaps and also to maintain the patency of frontal osseum that they created. And
I think
that is going to stay for a week. And
Yeah.
the silastic sheet on the other side is going to stay for 3 weeks. So that's kind of their post-operative management.
I
Any
think
reflections
what
on
is
the case?
it's yeah, I was just going to say it's highlighting as well. I think the change, you know, if you look back sort of in the UK 10, 15 years ago, maybe even in some departments, not even as long as that, these patients were having lumbar drains, they were having tracheostomies done as part of their pre-op preparation, all of which carry significant risk and significant morbidity. And so, you know, you see a real progression now where craniofacial resection is being done without lumbar drain, you know, without any incisions, bar, you know, the incision on the leg. And it's a real progression. I think for anybody that's embarking in skull-based surgery, it's a really good idea to audit your own results, because certainly when we started in Glasgow, even doing the pituitary surgery, every patient had a lumbar drain. But we quite quickly realised that it was unnecessary. And so we looked at our results, we audited it, we then did the patients without the lumbar drain and looked at it again and showed benefit. I think it's always important if you're making any changes to look at and audit what you've been doing before and then after as well, but always be thinking, how can we make this process more effective, you know, more efficient and safer for the patients?
Yeah, absolutely. And again, coming back to Prof. skull-based reconstruction, I mean, previously we have kept the balloons, the various
That's
type
right.
of nasal packs much longer, 5 days, 7 days, after keeping the patient in. But what Prof makes it very clear that if you got your multi-layer reconstruction right in the first place, so get it right in the first place, with good support, these are almost watertight seal, right, intraoperative, then you don't need all those things. You don't need those long-term packing, the balloon support. So there was hardly any support that was required to the flap. So that is quite fascinating. And the recurrence rates seem quite low. So around 2 to 3%, the immediate reconstruction. So that is quite fascinating, and it's a great learning. So that gives more confidence of people who are doing this type of surgery.
Yes.
And again, the importance of working as a team, multidisciplinary team with neurosurgeons, and also having a partnership with your anesthetic. The Prof's comment that we live together, that says it all.
Yes,
so,
yes,
yeah, I think
absolutely.
RES is a very unique unit. It's a tertiary, rather quaternary center, catering almost whole of the country. And they have developed right from the scratch this service together.
You have that support. I think it's having that good team relationship as well that allows you to push the boundaries of what you're doing as well, because you trust each other and you know that you have the support if you do have any complications, and that's required if you want to push forward, you know, what it is that you're doing.
Yeah, correct. And other important thing is we've seen all the variations of anti-ethmoid artery, how to deal with it. And I hope our junior delegates have sort of it helped them to tackle a bit of a fear that you develop about this practice. You don't want to go anywhere.
That's right.
But yeah, how close can you go if you know the anatomy, if you have the right ways of dealing with it? So, and even dividing the anterior artery, how you divide it by using the bipolar and staying medial, so avoiding all those complications.
That's right.
That was a great learning. So I think there's probably a good time to catch up with our supporters, Karl Storz and Medtronic, so we can view some of their technology, the gadgets. I think the gadgets are key, and the technology has really helped to propel our specialty forward.
Absolutely.
So let's catch up with what we have them with a mini break, and then we will get back to Trichy for recurrent JNA, and also if the prof is ready, inverted papilloma involving the maxillary sinus. We'll see you shortly.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't. With Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.